ladies and gentlemen. Welcome to the afternoon symposium 2 on COVID-19. My co-chair is Dr. Harsha Sachandra. And let me first introduce the first speaker, Professor Nilika Malavige, who's speaking on genomic sequencing for surveillance for SARS-CoV-2 variants of concern. Professor Nilika Malavige is Professor and Head of Department of Immunology and Molecular Medicine, University of Sri Jayawardenepura, Sri Lanka, and also a visiting academic at University of Oxford since 2018 after completing her doctoral studies at the MRC Weatherall Institute of Molecular Medicine, University of Oxford. She is a member of the Executive Committee of the International Society of Infectious Diseases since 2020. She is Fellow of Royal College of Physicians in London, the Royal College of Pathologists in 2015. She serves as an expert member on several government COVID-19 related technical advisory groups. She leads a large research group working on dengue and COVID-19. Her work on dengue has focused on factors that lead to severe dengue, identification of biomarkers, and mediators of vascular leak in dengue. Her work on COVID-19 is mainly related to immune responses to COVID-19 vaccines, immunopathogenesis, and determining correlates of protection against COVID-19. She has strong research collaborations with University of Oxford, and her laboratory is part of the A2CARES, which is one of the centers for research in emerging infectious diseases, which is a global network. She has won many awards and received many local and international grants. Professor Nilika Malavige.
Thank you so much, sir. That was very, very long. And this is such a pleasure to be talking to human beings who can be seen after a very, very long time. I'm talking about vaccines and variants. And towards the end, I'll be also talking about comparing the immunity of AstraZeneca with Sinopharm, which I think a lot of people want to know right now at 3 months since receiving the second dose. To start off with, I don't think I need to talk about how our Sri Lanka is with the rest of the world. There's a large epidemic going on in Europe, not so much in Asia, but again in USA. This is despite vaccination, and somebody might ask, why is there a large outbreak in Europe and these countries despite vaccination? This is because about 1/3 of the adult population, especially 40, 50, 60-year-olds, about 1/3 have not taken the vaccine because of this anti-vax movement in those countries. Although we have such a movement in our countries, it is not as bad as elsewhere. So although we do have some people not vaccinated, it is far, far less than Europe. And so this is an epidemic driven by unvaccinated people. However, the mortality rates are very much low, as you can see in this graph, which is good news. A large proportion of these countries have been vaccinated, so the vaccines seem to be working. Now, I think the questions we want to know right now are how long the pandemic will last. The biggest question, will new variants emerge and will we have to go back to where we were? And how well do these vaccines prevent against severe disease in the coming months or years? And basically, how do we live with COVID-19? Now, the virus has been evolving over time. Unfortunately, I haven't got a pointer with me, or a laser pointer to show what it means, but the top graph shows the Sri Lankan data of how the different variants of concern have evolved over time and in the world. This is not Sri Lanka, sorry, the global picture. And you can see alpha was a problem at one time, but if you take the whole world, it's a delta epidemic, and it's delta that is leading. And in the bottom graph, it just shows that although we have delta, which is almost the one and only variant in the world right now, there are several sub-lineages of delta arising. And why is delta dangerous? And why did it succeed in getting rid of all other variants of concern like alpha, beta, and delta? Is because of the simple fact that it is more transmissible, much more transmissible than any other variant that is currently known, and because of this advantage of transmission, it is survival of the fittest, and because of this transmission fitness, it has sort of got over all other, won the race against all other variants that are out there. Now, of course, every day in Sri Lankan newspapers, and sometimes we get stories about that variant, Sri Lanka is on alert of that variant, this variant, and people panic. And we know that there was some time people were worried about the epsilon, and because when you look at epsilon, I don't know if you can see it, I don't have a pointer. It does, okay. So the epsilon, the immunity for the epsilon is slightly less for the vaccines and also for the mu. And for the mu, it specially evades immunity, similar to the immune evasion by beta, and sometimes even less than beta. So should we be worried about mu and epsilon? So again, it's the survival of the fittest. If you take delta, delta is much more transmissible than mu or epsilon. I can use it from here. Yeah. Okay, so that's great. Okay, so this is mu, okay, so evading immunity. The important thing is all these variants are mu and epsilon is not as transmissible as delta. So if you take Ecuador, I got the spelling wrong, but anyway, Ecuador, we had these variants iota, mu, but as soon as delta hit Ecuador, mu was displaced and it's delta. And of course, mu was a huge problem in Colombia, but when delta hit Colombia, as you can see, the mu is vanishing. And Chile, again, there was lambda, and there was some, and mu, again, with the emergence of delta, these variants were swiped out. So one thing you need to remember is don't get bothered about news. Okay, every day, I think right now also there was a other than an alert was forwarded to me about new variants, and there were alerts about extinct variants also, that we are on the outlook for extinct variants. So just to let you know that as long as we have delta, delta will be with us for a very long time. It's not moving. Okay, so now the problem with delta is, of course, delta is multiplying. So delta has now got so many daughters. Okay, so we can call them delta and her daughters, where delta has so many daughters. And so people are worried about this delta plus. And although these daughters of delta don't seem to be worrying right now, we of course all the countries which are doing genomic sequencing are keeping an eye on delta and her daughters. Now, we have been sequencing from the very beginning of the pandemic, and when you compare Sri Lanka to the rest of our region, this is the CRO WHO region, we can't compare ourselves with UK or Australia, which have been doing so much more sequencing. We are sequencing 0.32% of our positive cases. We have a similar rate as Thailand, and we are far ahead than many other countries like Bangladesh, Indonesia, and India when it comes to the proportion of viruses being sequenced. But the WHO, of course, advocates that we should sequence 1% of our samples, and we have not gone there yet. Now, coming to genomic sequencing of Sri Lanka, this graph shows how the various variants of concerns changed over time. So this is the original Wuhan variant. We got alpha, and then we got delta. So you know that there are two colors of delta because we've got different deltas in Sri Lanka. And these are just the different types of delta we have in Sri Lanka, which I'll explain. Now, Sri Lanka has proudly managed to produce two deltas which are born and bred in Sri Lanka. So the world has named these two variants as Delta Sri Lanka sublineages called AY28 and A104. AY28 is mainly seen in the Western Province and these areas, whereas AY104 is mainly seen in Hambantota and the Northern Province and North Central Province. So these are Sri Lankan two variants that were emerged in Sri Lanka from the original Delta variant that came to Sri Lanka. Okay, it's not moving. It's not moving. Okay, right, it's funny. So this is the distribution of the AY28 Sri Lanka Delta sublineage. We have managed very successfully to give it to several other countries. And when you look at the countries which we have given it, you can see that the majority of Sri Lankan passengers going overseas actually go to these countries. And so people were actually worried. There was a lot of news about this UK Delta Plus variant, and the main reason that people were worried about this UK Delta Plus AY4.2 is because of this particular mutation A22V, which is also there in our own Delta AY28 sublineages. So probably our one is also quite more transmissible than the original mother Delta. And because we can't grow the virus here, culture the virus, we don't have BSL-3 facilities. Professor Malik Peiris, these have been sent to Professor Malik Peiris, and they are further under investigation. And this is A104, again the Sri Lankan lineage originating in Sri Lanka. And we have again given it to the main countries that Sri Lanka visits, strangely not to Australia. And this one, A104, doesn't seem to be very bad. It doesn't have many mutations different from the original Delta variant. So I don't think it's we need to be very concerned about AY104, which is in the news today. Okay, it's okay. So now, okay. So when it comes to COVID vaccines, I think what everybody wants to know is how effective are they with time? Are all vaccines the same? And what the future holds for vaccines? And we had the unique opportunity because Sri Lanka received so many different WHO vaccines, and we were able to do several studies on the AstraZeneca vaccine in healthcare workers, and the AstraZeneca vaccine was delayed in the general population, the second dose. So then we were able to assess the immunity of the second dose, in the absence of the second dose, the single dose immunity, how long it lasts for. Comparison of natural immunity versus AstraZeneca, the Sinopharm, how immunogenic is that, Sputnik. So all these things we were able to look at because Sri Lanka used, except for Sinovac, all the other WHO vaccines were used in Sri Lanka. And so we carried out all these studies in the Colombo Municipality Council vaccination sites, where we have a very good collaboration with, and also in Kandy, where the Sputnik and the Moderna vaccines were given. And in these studies, what we did was we were looking at so many different aspects. One was measuring antibodies to the receptor binding domain, because you know that the virus binds to the ACE2 receptor by the receptor binding domain, but it's mainly the neutralizing antibodies that prevent the binding of the receptor binding domain to the ACE2 receptor. So it's the neutralizing antibodies that are actually protective. We also looked at T cell responses and memory B cell responses. And for the neutralizing assay, we had access to this surrogate neutralizing test that was developed by Professor Lim Fa Van, who is also called Batman. He had done a lot of research on coronaviruses. And this, we were able to look at the kinetics of immune responses for this, using this surrogate neutralizing test very early in our population. And this assay is currently used widely in many vaccine studies. So it is this assay that we are using that many other vaccine companies like Pfizer is also, and AstraZeneca and so on, are using to evaluate the neutralizing antibody responses to their vaccines. Now, coming to the AstraZeneca. So at 3 months, how is AstraZeneca immunity like? This is from the data of our healthcare workers. And if you look at the different age groups, 20 to 30, 40 to 59, and over 60, there is no difference in the antibodies to the receptor binding domain. Again, there is no difference in the antibodies to the neutralizing antibody levels at 3 months since the second dose. And also, when you look at antibodies to the receptor binding domain of alpha, beta, and delta, quite a large proportion of individuals, over 50%, had positive responses to the receptor binding domain of all the variants, alpha, beta, and delta. All this data is currently available as preprints in the web, so anybody can download and look at this data. And how does it persist? Of course, this is the antibody responses to AstraZeneca with time. So we bled at 4 weeks. Then at 12 weeks, this is with a single dose, okay? And the second dose were given to healthcare workers at 12 weeks, and this is 24 weeks, which is 3 months after the second dose. Of course, neutralizing antibodies showed a different response. With the baseline at 1 month, they increased, but after a single dose at 12 weeks, you can see the neutralizing antibodies declined. But with the giving the second dose at 12 weeks, the neutralizing antibodies have shot up, which is very good news, and it was not age dependent. Everybody, even older individuals, had good neutralizing responses at 3 months following the second dose. Now, coming to Sinopharm, this is the same assays we do at the same time. And as you can see, the antibody responses to the receptor binding domain have fallen at 3 months following the second dose. These are just the receptor binding domain antibodies, and some people were seronegative. But most worryingly is the antibodies, neutralizing antibodies. As you can see, this is the cutoff value, and quite a large proportion of people had were seronegative. So basically, it's a negative result for if you use the neutralizing antibody test. They were negative 3 months following the second dose for Sinopharm. And when you look at antibodies to variants of concern, alpha, beta, and delta, irrespective of age group, the positivity rates were less than 12%, whereas for AstraZeneca it was over 50%. And if you look at the kinetics, so this is baseline at 4 weeks. 6 weeks is when the second dose was given, and this is 3 months after the second dose. The antibody responses for the receptor binding domain sort of persist, but the neutralizing antibodies, which are the important antibodies for protection, have come down, especially in the over 60s, almost to the negative levels. However, the T cell responses persisted, and 30% of individuals were positive for T cell responses at 3 months. Now, this is head-to-head comparison with Sinopharm and AstraZeneca for the receptor binding domain at 12 weeks after vaccination. This is 12 weeks after 2 doses of Sinopharm, 12 weeks after a single dose of AstraZeneca, and 12 weeks after 2 doses of AstraZeneca. So basically, 2 doses of AstraZeneca produced more immunity. And this is the neutralizing antibodies for Sinopharm, AstraZeneca 1 dose, AstraZeneca 2 doses, 12 weeks after each vaccination. And as you can see, AstraZeneca 1 dose produced more neutralizing antibodies than 2 doses of Sinopharm. But when it comes to the over 60 individuals at 12 weeks, this is 3 months after the second dose, about 50% of those individuals who received Sinopharm did not have neutralizing antibodies, whereas for AstraZeneca they did. So this is probably why the WHO, not just our data, based on other data as well, the WHO has made the recommendations. So just to summarize what we have found, the neutralizing antibodies were significantly lower at 3 months following 2 doses of Sinopharm compared to 3 months after a single dose of AstraZeneca and 3 months after 2 doses of AstraZeneca. But the T cell responses for Sinopharm persisted. So who should be given booster doses and when is the question. The WHO has recommended, because of waning immunity following 2 doses of Sinopharm, especially in old individuals, as I showed you our data as well, additional dose, which is a third dose, and it's not a booster dose, should be given at 3 to 6 months following the second dose in their primary immunization series. And just this is just data out from UK showing how useful booster doses are, because I think that's what everybody wants to know right now. And so this is a vaccine, unvaccinated, which is taken as baseline. So with 2 doses of AstraZeneca, this is efficacy is in preventing infection is about 44%, but with the boosters, 14 days after the boosters, it went up to 93.1%. This is 6 months after the second dose. All the boosters is given 6 months after the second dose. For Pfizer, the baseline immunity after 2 doses of 62.5 increased to again efficacy rate of 94%. So what should be our approach for the future? Who should be get the vaccines? Who should we prioritize the vaccines? Is it for children less to in the 12 to 15 age group, or those over 60 who got Sinopharm? And which approach should we take to have the minimum effect on moving forward with COVID, with minimum effect on economy and educational activities? And I would like to thank all our funding agencies and our main collaborators from University of Oxford, Professor Graham Mogg, Professor Alan Townsend, our collaborators from the CMC, Dr. Dinu Guruge and Dr. Ruwan Vijayamuni. And of course, all this was, we did all the work because of our huge team of individuals who went out there, got the blood samples and did all, just showed the antibody assays, but we did memory B cell responses, T cell responses and memory T cell responses. So a huge team is working behind all this data. Thank you.
Thank you very much, Prof. Nilika Malavige, for that excellent lecture. I think she answered lots of our questions. The questions we'll take at the end of the symposium once the 3 talks are over. Now I have the pleasure of introducing Dr. Anand Vijayvikram. I think he needs no introduction to a Sri Lankan audience. He is a senior consultant physician at the National Institute of Infectious Diseases. And I think from the first patient who was treated in Sri Lanka, he has been treating COVID patients. So there is no other person who is more qualified to talk about management of COVID-19 on a case-based, it's a case-based discussion. Over to you, Anand.
Thank you very much for your kind introduction, and thank you very much for inviting me and giving me this opportunity. So I'm going to discuss some cases. I think now most of our clinicians, physicians have managed COVID, so I don't know whether I can add a lot of things. But still, I think it's worth sharing our experience, all of our experience, so that we can improve in the management of COVID. Sorry. Why I said that it is important to discuss and share our experiences. Still, we have a quite high mortality rate, not only in Sri Lanka, even in other countries. Now, the initial estimates of mortality in COVID was around 3 to 5% when we look at data in China. However, when we look at the data in inpatients, hospital admitted patients, they had a mortality rate of about 15%. And a lot of these deaths have occurred during the, towards the latter part of the second week. If you look at the mortality rate from clinical trials, just to highlight the mortality figures in 3 highly spoken of clinical trials. In the Solidarity trial, there was a mortality rate of about around 12%. In the Remdesivir trial, in the preliminary report, the mortality rate was between 7 to 12% again. In the recovery trial where they used dexamethasone, there was a significant reduction with dexamethasone in the dexamethasone group when we compared with the control group. Even then, there was a 22.9% of deaths even in the dexamethasone group. So that is the mortality rate in this illness, even in developed countries. So it is important to have steps to reduce the mortality rate of hospital admissions. Now, initially we have been admitting all the patients, so our mortality rates were quite low. But when later, when it was changed, and the preliminary data shows only 20% needed hospital admissions in Sri Lanka after home-based care was introduced. If you look at this patient who was admitted early this year, a 94-year-old male, transferred from a private hospital with cough and fever for 4 days. And he was finding it difficult to walk and gradually progressive shortness of breath, known patient with ischemic heart disease, unvaccinated. Of course, the vaccine was not available at that time. On admission, his oxygen saturation was 92%, but improved with 5 liters of oxygen. He was hemodynamically stable. Later, he became confused. However, the oxygen saturation maintained with 2 liters of oxygen. And when you look at his investigations, he had some lymphopenia, and otherwise his CRP was high initially, and the creatinine was high. I think probably that was his baseline. And the chest X-ray showed patchy consolidation in all 3 zones of right lung and mid-zonal and perihilar region in left lung, and reported as could be COVID-related lung change. So this is a chest X-ray. And this is the subsequent chest X-ray done about a week later. Because of his confusion, we did a CT scan of brain, which showed age-related atrophy and a small vessel disease. And chest showed ground glass opacities with associated patchy consolidation. And in addition, he had nodular opacities in both lungs with bone destruction in all T12 vertebra and bilateral pleural effusion, suspicious of neoplastic changes. So this is a 94-year-old male with all these issues, coming with COVID pneumonia and hypoxia. So we gave him standard treatment, dexamethasone 6 mg daily, enoxaparin 40 mg, and later he was started on antibiotics. And he improved gradually. And his antibodies are positive, and he made a good recovery and was discharged after about 12 days from admission. So you can see how it can vary from person to person. This is a 94-year-old male with all possible comorbidities, lot of possible comorbidities. In spite of that, he survived. And he needed only the standard treatment, nothing else. When you look at dexamethasone, and there's a question, when to use and how much to use. The living guideline of WHO says dexamethasone 6 mg daily for up to 10 days. A dose of 6 mg of dexamethasone is equivalent to 150 mg of hydrocortisone, 40 mg of prednisolone, or 32 mg of methylprednisolone. So standard, this is the standard guideline, but we know there are a lot of discussions and ideas, opinions on regarding the dose of dexamethasone. However, I don't think there is any question about when to use dexamethasone, because the recovery trial data can I get the point? The right lower graph shows, now there are 4 graphs. The red one is the dexamethasone line, the black one is the control line, usual care line, and the right lower graph shows what happened when dexamethasone was used in people who did not need oxygen. You can see the mortality rate is higher actually in dexamethasone group. So therefore, it is pretty obvious that there is no place for dexamethasone in people who do not need oxygen. I wanted to tell this because still we see a lot of people are given dexamethasone. Thanks. Yeah. Now this shows clearly the dexamethasone, use of dexamethasone, what happens when it is used in people who do not need oxygen. And this is seen even in some intermediate care centers managed by private hospitals, unfortunately. So this has to be stopped because some of these people later come with other complications. But on the other hand, in other people who need mechanical ventilation, who need oxygen, there's a definite place or dexamethasone that improves the survival significantly. And then there have been studies, many studies done regarding what dose to be given. This is a retrospective study. I just thought of showing one study. There are many studies which show some benefit in higher doses, some shows disadvantage in using higher doses. Now, this study used methylprednisolone and compared with dexamethasone low dose. Well, it's not low dose, it's 6 milligram is, I would say, a moderate dose. And when that was compared, that suggests low dose dexamethasone for 10 days is superior to 3 days of high dose methylprednisolone pulse in preventing in-hospital mortality. There was a significantly higher mortality in people who had methylprednisolone in this study. There are many trials. So probably conflicting evidence, but in the recovery study we have got convincing evidence about the benefit of that. I think we stick to that dose. So we don't go for high doses of giving dexamethasone, 10 milligram BD and such doses. This 34-year-old male weighing 130 kilos was admitted on 18th of August with a history of fever for 8 days. On admission, his oxygen saturation was 85 on 5 liters. He was brought in an 1990 ambulance with oxygen, and when he came, this was his saturation. So we increased his oxygen with NRBM, then later we had to increase to 15 liters. So again started on standard care with dexamethasone and enoxaparin, catheterized, given complete bed rest. And these are his x-rays done in a couple of occasions. You can see how much the lung was involved. And this is the chart, monitoring chart we use. And you can see this is his oxygen saturation in red. The blue line shows the oxygen amount of oxygen he had. Sorry, the left side column is not seen. So he was managing for a couple of hours, and then again he started, saturation started to drop and dropped to 92 and then further. So we had to move him to the ICU and then started on CPAP. We gave him tocilizumab on 19th. Did not show any response. We had to intubate and ventilated him on 20th. This was his CT scan. You can see the degree of involvement in both lungs. And then he started improving. There was gradual improvement, and he was extubated on 27th of August. But still he was oxygen dependent. Then he was transferred to medical unit. From COVID ward, urine culture showed candida. He had persistent tachycardia. Because of this persistent tachycardia, even with slightest exertion, he was becoming hypoxic and tachycardic. His echocardiogram was normal, and we did the CTPA, and the CTPA showed filling defects in right lung. So now he is getting pulmonary embolism. So he was started on warfarin and stabilized. He had a gradual improvement, and so started him gradual pulmonary rehabilitation, gradual reduction of steroids, and he went home without oxygen and now coming for follow-up, and he's improving quite well. So in spite of his, again, with the weight of 130, when he came, I was pretty, I must say, frightened. Ventilating such a patient, you know, is a nightmare. But still, he survived. Now, this question, was it appropriate to give TOSI to this patient? Well, we had our arguments, we had our reasons. His oxygen demand was increasing, his CRP was high, his procalcitonin was normal. So we decided to give TOSI, but there was no response. Of course, everybody doesn't respond. Well, on the other hand, this is another case history. The SHO continued with this case history. It was a 39-year-old lady. She was pregnant with a PO of 32 weeks. Cesarean section was done and a dead fetus was delivered. The SHO continued saying her oxygen saturation was going down. We covered her sepsis with broad spectrum antibiotic and gave tocilizumab, but she continued to deteriorate. And this was her temperature chart. And she was given tocilizumab at this point. So was it correct? 2 days later, she was transferred to us for renal replacement therapy. She was in septic shock and died on the same day. This was a post in the WhatsApp. If anyone is looking for tocilizumab, last moment injection to recover life. Below is the contact received from a friend in pharma. There was a number. So this, unfortunately, this message has gone to public that it is a sort of a magic bullet, but it's a very useful drug in selected cases. So therefore, we have to tell people also that it is not a magic bullet to save everybody. Unfortunately, people spend lakhs now, and is now sold for more than 5 lakhs one dose. We have to tell the actual situation of TOSI to patients and their relatives also. And it can make the disease process worse if not used correctly. WHO guidelines says, living guidelines says, it reduces the mortality and need for mechanical ventilation with high certainty evidence. And the low certainty evidence suggests they may also reduce duration of mechanical ventilation. Now, in a pooled study, pooled analysis, there was a 27% reduction, or deaths were 20%, mortality was 27% compared to 36% in the control group. So out of 395 patients, 108 still died. So if it is given to 100 patients, still 8 to 9 patients who would otherwise die will be saved, but still another 27 patients will die. So that we have to, I think, tell patients and relatives, otherwise they get this unnecessary thing. And also we also tend to sort of sometimes as a defensive measure to use this. This 51-year-old male, husband of a doctor working in the ICU of a BHXXA, who was fully vaccinated, had symptoms since 10th, rat positive on 14th, managed at an ICC, then transferred to BH on 18th with hypoxia. He was started on dexamethasone, enoxaparin, ceftriaxone on 18th. Remdesivir also started on the same day. His CRP was 130. Procalcitonin is 1.52 on 18th. Oxygen requirement was increasing. He was given tocilizumab on 19th, and 19th procalcitonin was still high, 0.8. Is that correct? Giving toci again. And he was started on CPAP on 20th. From BH, he was transferred to us. The reason saying, despite decrease in CRP and procalcitonin, oxygen demand stays high and deteriorating respiratory functions. And his sputum growth, the significant coliform growth, chest X-ray was not actually typical of COVID pneumonia. And we did HRCT, and the CT showed bilateral consolidation, moderate to severe, less COVID changes, more towards superadded infections. Now remember, this patient was given toci. So this is, unfortunately, as I said, it is a very useful drug, but unfortunately it is abused too. And the sputum confirmed as Acinetobacter, so he was given appropriate antibiotics. His D-dimer was more than 4,000. We did a CTPA, which again showed pulmonary embolism and resolving pneumonia. So he was started on warfarin. Dexa was stopped at 10 days. He improved slowly. Since the improvement was slow, we did another HRCT around day 20, which showed pulmonary fibrosis. Then he was started on methylprednisolone pulse therapy, followed by oral prednisolone. And he improved well, and he discharged home just 3 days ago, without oxygen, of course. So when to do suspect P? Is measuring D-dimer helpful in hospitalized patients? This study published in JAMA, this shows a normal D-dimer level basically exclude pulmonary embolism. However, elevated D-dimer was almost universal in COVID-19 patients. So elevated D-dimer does not confirm COVID, or maybe a strong, sorry, confirm PE, or may not be strongly suggest PE even. But if the D-dimer is negative, we can definitely say it's not a pulmonary embolism. So we had to decide when to do CTPA. I think probably with D-dimer and clinical parameters, we have to decide when to do a CTPA. So when we are managing these patients, there are many issues. They have multiple comorbidities, multiple complications of COVID like pneumonia, thromboembolism, can be pulmonary and systemic also, pulmonary fibrosis, other organ involvement. Then as we all know, prolonged ICU stay lead to hospital-acquired infection, ICU myopathy, and prolonged ventilation leads to hospital-acquired pneumonia and multi-drug resistant infections. And then of course they get side effects of various drugs we use, like high blood sugar, steroids-induced myopathy, hypokalemia, and so on. This 65-year-old male was admitted, this just to highlight the issues we face in these patients. Last 15th, about 2 months ago, with fever and cough, a diabetic and hypertensive patient. When he came, his saturation was low. He was started on a standard care. We had to increase oxygen gradually. On 29th, after 14 days after admission, that is around 18th or 19th day of illness, we had to intubate and ventilate the patient because our saturation was going down. This was his X-ray around that time, and the CT scan done around the same time. You can see a lot of organizing pneumonia seen. And later we started with the input from respiratory physicians. We started him on prednisone, dose prednisolone later. But then 4 days later, we got a blood culture growing candida and bronchoalveolar lavage grow pseudomonas. In spite of that, we were able to extubate him, treat him and extubate him. Still he needed intermittent CPAP and nasal high flow oxygen. And we transferred him to the ward later, but unfortunately his oxygen saturation was going down. He was becoming more dyspneic. We had to readmit him to the ICU, electively intubated and treated with antibiotics because we believe he was getting a secondary bacterial infection. And he responded to antibiotics, and we were able to extubate him again on 8th. And now he is recovering, and we are planning to send him home on oxygen because still, even now with slightest exertion, he gets dyspneic, and this is the latest HRCT. You can see how much fibrosis has set up. So it is very important to identify these aspects. Some of the aspects I want to highlight: staff involvement for close monitoring and attending to patients, especially for patients who are in ward, not in ICU, with CPAP and nasal high flow. Because often we have to adjust it, make it correctly, because patients tend to pull this out, and that's why they are not improving sometimes with this. And of course, we have to control blood glucose, electrolytes, nutrition, physiotherapy, and of course, there's a huge place for antibiotic stewardship. And in my opinion, the most important aspect in ICU care is the infection control measures, because these people, most of them die of secondary infections, hospital-acquired infections, because of many reasons, as we discussed. I think I have to briefly mention about this also, the Casirivimab and Imdevimab, or popularly called Reganco, which is now available in Sri Lanka. What we need to understand in this, and then approval for this was given to use in people who are antibody negative, because the trial studies showed a higher incidence of deaths or higher incidence of hospital admissions and deaths in people who are antibody positive who were treated with this antibody cocktail. So it's again not a magic bullet, only for people who are antibody negative and immunosuppressed patient. And of course, this appeared a couple of days ago. This is false news. No committee has approved this yet. We are studying this because this, again, there are a lot of other issues related to this antiviral pill. So it's again not something which is approved. Right, thank you.
Thank you very much, Ananda, for that detailed lecture, taking us through the difficulties in managing COVID cases and raising and highlighting certain issues in the management. I think we'll take questions at the end of the symposium. it is my pleasure now to introduce a third speaker. He's going to talk to us on post-COVID complications. He's Dr. Pathipan Pillay from UK. He graduated from the Jaffna Medical Faculty, Sri Lanka, and worked as a house officer and a senior house officer in Colombo before leaving for the UK. He did the final MBBS again in Dundee and requalified in 1993. After his junior doctor training periods both at St. George's Hospital in London and Leeds, he became a consultant in 2000. And since 2001, he has been working as a chest physician at Luton and Dunstable University Hospital. He is a clinical director for the respiratory department. His main interests are medical education, non-invasive ventilation, obstructive sleep apnea, and tuberculosis. He has always had a passion for medical education and assessment, and he was an undergraduate sub-dean tutor for the University College London Medical School for 6 years, and has extensively contributed both in teaching and assessing students and regularly organizing final year MBBS examinations. He obtained the postgraduate certificate in medical education, University College London and Royal College of Physicians in London in 2014. He has been an MRCP PACES examiner for more than 16 years in the UK and centres overseas, and has conducted the role of chair examiner in the UK and abroad, and he is a host examiner in the UK. He is a deputy director of examination for Royal College of Physicians, Edinburgh, and mentor for registrars and new consultants for the RCPE. I warmly welcome Dr. Pathipan Pillay. He's no stranger to us. Over to you, Dr. Pillay.
Thank you very much. I hope you can hear me.
Yes, we can, yeah.
All right. Good afternoon, everyone, and thank you, Chairman, for your kind introduction. And it is so good to be with you all this afternoon, and I thank Sri Lanka College of Internal Medicine for inviting me. I am a practicing clinician. I am a chest physician, and I have been at the front line in the last 18 months looking after COVID patients. And I also developed and implement a post-COVID follow-up clinic in our hospital and the sister hospital. So the presentation, what I am going to say in the next 22 minutes is purely based on my experience and my colleagues' experience rather than large amount of evidence. Let me start by showing this case. She's a previously fit 45-year-old lady with no known medical problem in the past, presented to her GP with the smelling of burnt food for 2 weeks. She denies having any respiratory symptom or fever. The GP did a COVID PCR test and this came back positive. After 4 weeks, she developed extreme tiredness, mild breathlessness, intermittent palpitation, and bilateral lower chest discomfort. And she was referred to me for further assessment and management. I just want you to take a few seconds just to reflect and just to see what you would do for this lady. So ladies and gentlemen, for the next 20 minutes, what I'm going to do is I just want to cover the topic by just saying a little bit of pathophysiology of the acute COVID, because it does help us to understand what is going to happen in the post-COVID complication or in the chronic period. Just to define what is post-COVID syndrome and the long COVID, the risk factors associated with patient having a chronic problem, and the burden or the prevalence of complication on the healthcare system, and the clinical presentation and the system involved, and the investigation and intervention. I just want to quickly just show this very, very crowded flow chart. I just want to focus that only, 20% of us, when we inhale the virus, get into problem. 80% of us, we succeed, or we successfully get rid of that virus before that get into the lower respiratory tract. If that goes down in those 20%, it invade and infect the type 2 pulmonary alveolar epithelial cell, going through the ACE2 receptors, and not everyone, a group of patients develop this cytokine storm, and the group of patients, the same patient or the different, develop a large amount of viral load. Since the entry, the portal of entry to the body is the respiratory system, invariably the respiratory system going to get affected in those 20%. So they can have a COVID pneumonitis, and the CT showing, as Dr. Vijay Vikrama showed, bilateral patchy consolidation, peripheral consolidation. So you are going to see this group of patients in your post-COVID time in the follow-up period with complication or the symptoms of respiratory problem. So I think, when you have a patient, we don't know who is going to have this cytokine storm. Not everyone is going to get the cytokine storm, and who is going to have large amount of viral load. Because patients or people behave differently, maybe due to the underlying immunological issues or the comorbid condition, they don't all behave in a similar way. So the pathophysiology, there is high viral load and lymphopenia. There is hyperactivation of the innate immunity leading to pro-inflammatory cytokine storm. That leads to endothelial inflammation and endothelial damage. There is hypercoagulability state and microvascular thrombosis. And just imagine these are the acute phase, but these are going to persist, and there is chronic sequelae from that. It can lead to multiple organ failure. And we also don't know, there are few group of patients, they do have a very short hyperinflammatory state, and there are group of patients, they do have a longer period, maybe from 2-3 days to 3-4 weeks. So it is going to impact on the recovery and the post-COVID time with the complication. When we look at the timeline, that almost, 80-90% of the patient get rid of the virus in 4 weeks and they recover. If they continue to have symptom or develop new symptom, and after 4 weeks and before 12 weeks, we call it an acute post-COVID period or syndrome. And after 12 weeks, we call it a chronic post-COVID syndrome. So the acute post-COVID syndrome is ongoing symptomatic COVID, is a symptom persisting 4 weeks beyond initial infection. And the chronic post-COVID syndrome is a symptom persisting beyond 12 weeks. And then the term comes a long COVID. That is a sign and symptom that develops during or after infection, consistent with COVID-19, continues more than 12 weeks or 3 months, and not explained by alternative diagnosis. So we are bound to, we have to exclude all the possibilities before telling your breathlessness is not due, it's due to, not due to any organic cause. So you have to exclude all the possibilities. So what are the risk factors? If you have a severe illness, it's going to affect. Longer the illness going to have a problem in post-COVID period. ICU admission and the duration of admission and the duration of invasive ventilation and non-invasive ventilation. Advanced age, of course, and comorbid condition. We all know the respiratory disease, obesity, diabetes, cardiovascular, and so on. and also the exacerbation of underlying medical condition at the time of the diagnosis of acute, and how is whether they have repeated exacerbation after that during the post-COVID time. When you look at the clinical presentation, the main problem, as I said, the portal of entry of this virus is the pulmonary system. So I think the main problem is in the lung, but we do get large amount of extra pulmonary manifestation, especially neuropsychiatric manifestation, cardiac manifestation, and a few other things as well. So I think, this is a patient again, the acute patient, 11 days apart. The first X-ray is the admission X-ray, and that one after 11 days, and intubated and ventilated bilateral extensive pulmonary changes, so COVID pneumonitis. And this patient came to my clinic after 2 months, and still the X-ray showing bilateral changes, very much better. And the CT scan showing bilateral changes, almost organized scarring now, mostly in the peripheral region. We thought she may get better, and came back after 13 months, again persisting changes. So these are the group of patients going to come to your clinic, or general medical clinic, or the respiratory clinic, telling that they have got chronic cough and breathlessness. And when you look at the pulmonary system, it can be due to many causes. It can be a prolonged bronchial hyperresponsiveness due to the insult of that infection the patient had a few months ago. It may be due to the fibrotic lung disease, traction bronchiectasis, pulmonary vascular disease because of the endothelial damage and remodeling. 5% of the patient have got pulmonary embolism, not at the time of diagnosis, misdiagnosis, and diagnosed later on. Cavitation, pneumothorax, and so on, all those things. So quite a large amount of problem the respiratory physician look after when the patient come to the clinic. When you look at all the diagnoses of COVID patient, 10% develop a significant lung inflammatory response, and 15% develop restricted lung disease. It may be due to the interstitial lung disease, maybe a pleural disease, very, very uncommon, or maybe some muscle weakness and not breathing well, so restrictive defect. If you look at the patient who were admitted and discharged from hospital, I think invariably almost 80-90 would have had respiratory involvement. Out of those, when they look at that in the post-COVID clinic for the follow-up, 52 of them had respiratory impairment, mild to moderate reduction in DLC or the transfer factor, restrictive pulmonary physiology. Respiratory disease in 29%, out of those fibrosis in 12. CT scan abnormality, it may be a tiny abnormality, but the CT is not normal in those patients, 55% of the patient, and reduced exercise endurance. We do come across patients, when we do the lung function relatively normal, but they are very, very breathless. Very difficult to explain that degree of functional impairment is disproportionately high compared to the physiological impairment. It may be due to the muscle weakness, due to the deconditioning, or maybe due to non-organic cause, maybe depression, not very motivated, feeling low, and so on. There are cardiac issues. I'm not going to go through this in detail, but I think, as a chest physician or the general physician looking after a patient in the clinic, coming with a breathlessness or chest pain or palpitation, you are bound to look into both cardiac and respiratory areas. They do develop myocarditis, can go on hypertrophy, focal cardiac fibrosis, and coronary atherosclerosis. We had 2 patients missed in the post-clinic coming with the very, very atypical chest symptom, and we did not think about underlying coronary artery disease. Both were quite young patients as well. There are many patients with nervous system neurological symptom, mainly loss of taste, smell, and few nerve pain as well. So I think, I mean, this is quite a big burden as well in our post-COVID follow-up clinics. The other system are affected as well. I just want you to just focus on the immune system, almost like an autoimmune manifestation, Guillain-Barré, rheumatoid arthritis, and in a pediatric population, few cases of Kawasaki multisystem inflammatory disease. What I'm telling is it may be starting at the acute phase, but I think there are cases were missed and manifested later on, or the late diagnosed. So it's better to have these ideas that look at a global picture when you have a patient in front of you. It is a very big issue, the mental health issues of stress, depression, anxiety, delirium, and psychosis, and so-called the brain fog, problem with memory and concentration and cognitive impairment. There are a large number of patients, they don't seek medical help or advice, and it's underdiagnosis or underdiagnosed or under-recognized. So it's better to explore those symptoms when you have a patient in front of you. The study is showing that fatigue and sleep disturbances were reported to be the most common during the first 4 weeks in the acute post-COVID period, almost 40%. And the fatigue, anxiety, and breathlessness are common in the chronic post-COVID period. How we are going to assess these patients? So as I say, it's a multi-system disease with large amount of symptoms when you have a patient during the post-COVID time in front of you in the clinic. So I think, as a general physician, you have to have a broader way of assessing whether this is in a patient with the breathlessness, could that be a cardiac or pulmonary, or whether it's a thromboembolic illness. And they may have a neuropsychiatric issue is the main one, or something in the abdomen, renal or gastrointestinal issues. So I think it's almost, in the assessment, I think we are depending more and more on history taking now, because of the risk of infection risk and doing virtual clinics. So going back to the good old art of medicine, taking a good history, getting a history of the duration of the acute illness, whether the patient was admitted to ITU, the severity of the symptom, what are the comorbid medical conditions the patient has had, and is there any suggestion of exacerbation of his pre-morbid or the comorbid condition currently. Of course, there's no substitute for doing a good clinical examination. It is important. We have missed many cases, many pathology by not examining patient. Probably the same practice is followed in Sri Lanka as well, that virtual clinic, sometimes I feel is waste of time, and you cannot practice the full art of medicine. So there are pitfalls, and if you can, it's better to examine the patient, thinking about all your possible differential diagnosis. When you assess, also ask these questions. Is it related to the underlying COVID-related complication? Is it related to the exacerbation of pre-existing medical condition? Or am I dealing with a new pathology? Could that be lung cancer? Could that be tuberculosis? Or is it underlying coronary artery disease, or so on? So ask these questions when you have a patient in front of you at the end of your assessment and revisit. Investigation, I just put the respiratory and cardiac investigation for the patient with the breathlessness. You will end up in doing a chest X-ray, but if you are going to do an HRCT or CT pulmonary angiogram, irrespective of the chest X-ray finding, then better go for the scan first. Pulmonary function test, 6 minutes walk test, echo, and other things we'll do. Of course, I'm just focusing on the breathless patient, but if you have a patient with a neurological condition, you may do an MRI or nerve conduction study and so on. So this is the thing we do. And of course, I think, you are going to have a group of patients with post-COVID complication in the lung, in the heart, in the hematological aspect and the nervous system. So if you identify the patient and if you don't have an expertise, you are going to refer these patients to a specialist. For hypoxemia, for oxygen, home oxygen or oxygen treatment. Sign of severe lung disease, you are going to do the forward referral, referring to the cardiologist and so on. But you are also going to have patient, everything is normal. So going back to my case, that this lady was in front of me, was really suffering. She was perfectly well. My examination perfectly normal, no respiratory signs. Cardiovascular examination perfectly normal with the normal P2 and normal blood pressure. JVP was not elevated. Only thing was her pulse rate. It may be due to anxiety, maybe due to something. So I was forced to do the investigation one by one and almost did all the investigation which I mentioned before, and all came back normal. So we are going to have this group of patients as well. There are patients with organic problem underlying organic causes there, and there are patients without anything. So this is probably going to come under the long COVID group. So how are you going to take this further? I think, the main thing is not only the medical professional, all the other professionals are coming in managing, and also the patient contribution is also needed. So it's a holistic multidisciplinary assessment, assessing the breathlessness and supporting that, retraining the breathing, and psychosocial assessment, anxiety management, and of course rehabilitation if that need to be done. So these are the things. It is so difficult to manage this group, as you could see there, but I think, it's contributing in my clinics around 20-25% of the post-COVID patients. So ladies and gentlemen, this is my last slide. So I was trying to cover my topic by saying that the pathophysiology, and I also mentioned about the definition of the post-COVID syndrome and the long COVID, and the risk factors for people developing post-COVID complication, and the organs involved, and the basic assessment, how we are going to assess these patients and manage them. That's all I wanted to say, and thank you very much.
Thank you very much, Dr. Padrivan Pillai. We'll be seeing more and more of these post-COVID things than the COVID in future. In the interest of time, since we have to start the next symposium, we'll not take any questions from the audience, but they are free to ask the questions from the resource persons later. And could we have the speakers to the podium so that we can give the certificates? May I have Dr. Harsha Chandra to present the certificates? Dr. Nilika Malavige. And Dr. Ananda Vijay Vikrama. Dr. Parthiban Pillai's will be a virtual certificate name. Thank you very
Thank
much.
you.